Dr. Baliga here. This podcast is a multiple choice question preparation for the boards from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at UCSF. He also completed his medical school and residency training there. He works as a hospitalist with a clinical focus on perioperative medicine. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine. A 47-year-old man with diabetes will undergo cholecystectomy. He uses 20 units of glargine insulin every morning and 5 units of regular insulin with each meal. He also takes metformin twice daily. Which of the following strategies for diabetes management on the morning of surgery while fasting is the most appropriate? A. Continue metformin and hold all insulin. B. Continue metformin and glargine insulin and hold regular insulin. C. Hold metformin and glargine insulin and continue regular insulin. D. Hold metformin and regular insulin and reduce the dose of glargine insulin. And E. Hold metformin and all insulin. And the answer is D. Hold metformin and regular insulin and reduce the dose of glargine insulin. Diabetes management in the surgical patient must be individualized. However, oral agents, including metformin and sulfonylurea, should be stopped. In this fasting patient, the continued use of mealtime regular insulin is unnecessary and can lead to hypoglycemia. It's reasonable to continue some glargine insulin, which maintains basal glycemic control and can prevent perioperative hyperglycemia, although the dose may need to be reduced. Patients with diabetes are at increased risk for surgical wound-related complications, including infection. Some studies suggest that tight postoperative glycemic control may reduce this risk, as well as overall mortality in cardiac surgery patients. However, subsequent trials, which include a wide variety of surgical patients, showed increased mortality with intensive intravenous insulin to achieve normal glucose levels. Thus, tight perioperative glycemic control, that is a glucose between 80 and 110 milligrams per deciliter, should not be pursued in most patients. Due to the risk of hypoglycemia in fasting surgical patients, oral hypoglycemic agents should be held prior to surgery and only resumed when the patient is eating adequately for surgery. While metformin does not cause hypoglycemia, the risk of lactic acidosis in the perioperative setting requires that it is held prior to surgery as well. Type 1 diabetics require insulin to prevent ketosis. They often require continuous insulin infusions when they undergo major surgery, particularly if a prolonged fasting period is expected. For type 2 diabetics who take insulin, a common strategy is to hold short-acting insulin and reduce the dose of long-acting insulin by 30 to 50% when the patient is fasting prior to surgery. However, insulin management must be individualized for all diabetic patients. This short case scenario is from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at the University of California, San Francisco, where he also completed his medical school and residency training. He works as a hospitalist with a clinical focus on perioperative medicine. He directs the medical consultation service and co-management with neurosurgery service and regularly teaches about preoperative medical evaluation, perioperative medicine to residents and practicing physicians. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine.